All right. Hello there, everyone. Good afternoon. We are so excited to welcome you to this month's Canna Talk. My name is Genesis Emery, and I'm the Director of Marketing and Public Relations for the Society of Cannabis Clinicians. On behalf of the SCC, we couldn't be more excited to have you all today and to see you for our upcoming Canna Talk feature. We are so excited to bring you the latest educational insight on this month's featured course on dosing and delivery of cannabis medicine, led by our world-renowned herbalist and medical cannabis expert, Dr. Deborah Malka. You guys are in for a real treat today. Before we get started, let's quickly go over a few brief housekeeping rules. Please kindly make sure that you mute yourselves at all times. In the event that you need to step away, please make sure that you turn off your video. And also, don't forget there'll be plenty of time and room for questions at the end, so please be sure to submit your questions in the chat box on your right-hand side throughout the show so we can get as many of those answered for you guys as possible. Also, by the way, in case you guys didn't know, you can now purchase Dr. Malka's featured course of the month directly on the SCC's course page. What's even better is that this course is featured as a discount this month for 15% off for SCC non-members and 20% off for SCC members. Purchase your course today, and don't be sure to take advantage of our limited time offer before the sale ends. Other than that, please enjoy, sit back, relax, and enjoy another exciting and educational segment of Canna Talk with Frye and Wilson King, featuring Dr. Deborah Malka. Without further ado, I am pleased to introduce you to the SEC's Vice President and the co-host of Canna Talk, Dr. Janester Wilson King.
Hello, everyone. It is a pleasure that you all are here again this afternoon for this month's version of Canna Talk. It is my great pleasure to introduce Dr. Deborah Malka. She's a good friend and she welcomed me into the Society of Cannabis Clinicians years ago. Dr. Malka is a holistic family medicine physician specializing in cannabis medicine. She earned her PhD in human genetics from Columbia University and studied both natural and traditional medicine with degrees from the University of New Mexico School of Medicine and the Santa Fe College of Natural Medicine. Dr. Malka is the past faculty director of the SCC's 2015 clinical cannabis curriculum. She and Dr. Kerr started the whole cannabis curriculum training modules for SCC and anyone else who wants to wants to learn. She continues to serve as a mentor and a friend. Welcome, Dr. Malka. All right, today we're talking.
I am so happy to be here.
Good, thank you, thank you. I should have given you a pause there. Well, Dr. Malka's module is on delivery and dosing. So I'm going to ask the first question. Why does the delivery method matter, Dr. Malka?
Well, generally people aren't aware that different cannabinoids have different absorption and bioavailability through different delivery methods. So that's one thing. You can't just give a prescription and expect the same dosage to be received through different delivery methods. For example, in sublingual dosing, it was found that CBD is absorbed less, considerably less than THC. This hasn't been studied in detail, but you can't assume that when you give a prescription for dosing that you'll get the same amount through the different delivery methods. The other thing about why the delivery matters is that, as we will see a little bit later on, some delivery methods actually impart a different profile of cannabinoid metabolites. So, and some reach the brain and some don't. So you can really play around a lot with choosing the delivery method to give which cannabinoids to go to which site that you want.
Nice, and that's very
Okay.
important in different delivery methods for sure. Dr.
So,
Frye.
yeah, Deborah, I wanted to ask, so how does the delivery method affect the level of, influence the level of psychoactive effects?
That's great. There are 7 or more different delivery methods, and at least 2 of the 7 methods offer no psychoactivity, even if THC is present. I shouldn't say that. Even if it's a THC dominant plant. For example, when you apply cannabis topically, not enough reaches the central circulation to have the cannabinoids and the terpenes really affect your brain. So you can put THC, CBD, THCA, you can put anything on topically, and rest assured that there's a very minimal chance that you'll feel any psychoactive effects. That's one thing. But the other delivery method that I like to promote is raw cannabis usage. And in the raw form, the cannabinoids are cannabinoid acids. And so there's going to be no psychoactivity, even if you're growing a marijuana plant as opposed to a hemp plant, a plant with a lot of THC, because you'll be getting THC acid. So those 2 methods, actually, there's no psychoactivity. And then there are some intermediate methods, not intermediate, what should I say? There are some methods that can reduce the psychoactivity. For example, smoking, vaporizing, inhalation gives you full-blown, immediate, absorption into the bloodstream. Oral ingestion gives you full-blown, immediate, not immediate, a little later, but absorption into the bloodstream. And it also produces a psychoactive metabolite that increases psychoactivity. So oral methods give increased psychoactivity. Topical methods give no psychoactivity. Sublingual and rectal, for example, give reduced psychoactivity because they're absorbed into the bloodstream before that psychoactive 11-hydroxy metabolite is formed. So you can really regulate the level of psychoactivity through the delivery that you choose.
I have a question regarding the term psychoactivity being, we all know that we're talking about intoxication versus.
Excuse me, can we have questions we'll have questions from the audience a little later in the program, if you don't mind.
And what he's touching on, and I was just going to clarify that when we're talking about psychoactivity, we're using the word in terms of the impairing effect or the euphoric high or the dysphoric effect that some people experience with THC. We're not necessarily talking about the anxiolytic or the mood elevation that may result from activation of other receptors. So when we use the term psychoactive, I think we're really talking about the euphoric high or the impairing effect of cannabis. Correct, Deborah? Are we talking about that?
In general, because I've been in this field so long, they've always referred to the psychoactive effect as a detriment. So this whole thing about choosing other kind of delivery methods would be to decrease the negative detrimental effects of THC. But in truth, it's just really about absorption, a level of cannabinoids, really. More absorption, you get more effects. Less absorption, you get less effects. So, or more absorption to the brain, more psychoactivity if it's THC, but more of everything if it's CBD. So it's really complex. But yeah, these terms are always in flux, aren't they?
Right. And that's, I'm sorry.
No, I was just going to say that when we're talking about this, I think it's more of the direct effect of THC on the CB1 receptor, as opposed to some of the other benefits that we can experience with cannabis in terms of mental health issues like anxiety and depression. But we're speaking specifically about THC effect on the CB1 receptor. Okay, sorry, Janester, go ahead.
Yeah, no problem. That's actually what I was going to say. So thank you. No problem. I can move on now. But it also is important to distinguish between psychoactivity and impairment. And you know, it's probably important when we start saying these terms that we define what we're talking about beforehand. So we appreciate that question for clarification. I wanted to try to move on to a different subject. We know that many things affect the dosage of cannabis, affect how you react to it, how the effectiveness is. And there are things like set and setting that we talk about with patients and whatnot. What are the 4 basic considerations that affect dosage, Deborah?
Well, there's so many things that affect dosage, but there are 4 main ones in my mind. The first and foremost is you have to have your prescription or your recommendation or your determination of what you want to be in your cannabis. It's getting more complex these days, but are we talking about which cannabinoids, which terpenes? Because you need to have your prescription. So dosage is not the same, and you need to know whether this is going to be provided by a pure cannabinoid or a full spectrum plant. So you need to have your source defined. That's one. Source defined. The next several considerations really have to do with the individual and how the individual recipient or patient manages their cannabis intake. And people don't talk about this enough. One common term that comes up a lot is, what is the individual's endocannabinoid tone? That is the state of activation, homeostasis, overactivation, underactivation of cannabinoid receptors and their interaction with endocannabinoids. So, for example, a person who has a deficient endocannabinoid tone might need more exogenous cannabinoids, i.e. cannabis. Someone who has a hyperactive endocannabinoid tone might be very, very, very sensitive to cannabis and need a much lower dosage. So that's 2, endocannabinoid tone. What's your source? What's your medicine? The third one is you need to know whether you're dealing with a new patient or a chronic user. So we call new patients, new to cannabis, naive users, because the naive users will need a much lower dosage than the chronic users who have acclimated their receptors to the cannabis. That's known as tolerance formation. And there's going to be almost a 10-fold difference, I would say, at least, in the dosing between those 2 categories of patient. And then the 4th one is you need to understand what other chemicals are in a person's system, i.e., what drugs may they be taking. For example, a typical one is if you've got somebody on, 80 milligrams a day of OxyContin, having a few puffs of cannabis, even in a naive user, may be less likely to impact their chemistry. So if somebody's on strong medicine from elsewhere, then you might have to use a lot more cannabis than you would ordinarily otherwise have needed. Conversely, if they're weaning off of a medicine, like let's say you're replacing a sleeping pill with cannabis, then you may need to actually change your dosage of the cannabis as the other medications are being altered. or alcohol or any other substance that you're substituting for, you're going to have to change the cannabis dosage as the other substances change. So that's my little quick for checklist.
Yeah, that's good. So there are so many nuances involved in the use of cannabis that it's important to let patients know that all of these things enter into the effectiveness of your cannabis dosing. So there's some things we have to pay a little more attention to, and that comes from, of course, getting their history and knowing your patient and recommending the correct items, and also explaining to patients that various things you do will affect the effectiveness of your medicine. And that's different than a lot of the pharmaceuticals. So that's a new concept for a lot of patients to have to deal with. Thank you, Deborah. That's very good.
I'd also interject that that how patients metabolize these cannabinoids also affect dosing. Oftentimes, if you have a patient who has a history of having every side effect known to man for other pharmaceuticals, that might suggest that they're slow metabolizers. So that dosing, you want to start very carefully, low and slow for sure. And then there are others who never get the effect of pharmaceuticals and may be high metabolizers. And so they may chew everything up before they can get a therapeutic plasma level. So that's another consideration in the history when approaching dosing, I would think. So you spoke about the difference between the cannabis naive patient and the chronic users. So what is the dosage difference that we would expect? And are there some things we can do to help chronic users become more sensitive to cannabis so that they don't have to dose so high, which could also translate into cost savings when purchasing medication?
Yeah, this is a really common thing that I dealt with in my practice a lot, is to find that sweet spot where you actually don't live in the oversaturated range all the time, which, tends to happen a little bit with younger cannabis users. Older ones are more cautious. Younger ones tend to kind of the more is better kind of idea. Well, that's actually not the case. So usually when you start using cannabis, you might be affected by something like a 1 milligram cannabinoid dose, 1 milligram of THC or 1 milligram of CBD if you're a new user. That won't last long. Usually you have to go to, let's say, 5 milligrams of THC or 10 milligrams of CBD. Let's just say that that's an average maintenance dose. In my experience, if you stay on that level in the 5 to 10 milligram cannabinoid range, you actually will not achieve saturation. Not everybody, slow metabolizers, maybe, but you can stay on that as a dose 2 or 3 times a day for an indefinite period. Of course, there are exceptions. But once you get into the 20 milligrams per dose range, you're going to start to saturate your cannabinoid receptor sites. And then the more you use, the less effect you get. So that's what happens when the receptor sites are saturated and you've created tolerance. And then people generally just continue to use more because it's not working, so I need more. So in herbal medicine, there actually is a concept called the herbal holiday. And I didn't make this up. It's in herbal medicine. And it's when you actually take a break from the botanical, number one, to let your body reset and see what new homeostasis has been achieved. And number two, in order to see if you've made any progress with your condition and, you know, how much of the medicine you still need. So we call it a tolerance break generally in cannabis circles, but it's not unique to cannabis. And that can vary anywhere from a day a week to a month per year. People do all kinds of different regimens, but when you lower your receptor site capacity, saturation, then you can go back and use a smaller amount again. However, people really need to be coached in this because they'll go right back up to their tolerance of the 10 to 20 to 30 milligram doses. And so it needs to be, I really think it should be part of cannabis dosing protocols, is to teach patients how to stay in that sweet spot of just under saturation, where every time they take the same dose of the medicine, they're actually using it all. And one more strategy I'd like to point out for tolerance reduction. You know, we've all had these patients that say, no, I can't do without my cannabis for one day. You know, maybe a half a day a week. I can't do without it for one day a week for whatever reasons. And then we can go into replacing the components. So you can switch from THC to CBD and still have full terpenes and full entourage of the plant. Or you can switch to a raw method and switch from THC to THCA. So there are many benefits we get from the cannabis dosage that's not just the pure cannabinoid. And so that's what we're really trying to lower the levels of, is the pure cannabinoids. So switching the cannabinoids around while still taking cannabis is another strategy to reduce tolerance.
That's excellent. Those are some good strategies to employ and to teach our patients about. That's for sure. You know, I'm sure any of us that have been doing clinical cannabinoid medicine will have a patient who's doing great all of a sudden say, oh, my symptoms are back and I'm using the same dose and it's no longer working. It's tolerance that has been created. But you know, there is sometimes tolerance is good because you don't get tolerant to the effects, but you get tolerant to the psychoactive effects, the impairment portion, so that you can function while still taking your medicine. Do you find that may be an important aspect of tolerance? Maybe tolerance is something that's a benefit?
In patients who medically, due to point number one, need to have their source medicine be taken in really high doses, like for cancer treatment, let's say, or for seizure control, those are usually really high doses, then you're gonna have tolerance. There's no way around it. And you know, you just have to stay on the high end. But personally, the real answer to that question is, I believe that when you supersaturate the cannabinoid receptors, you're actually putting your endocannabinoid system out of balance. And it's not a good place to live unless you have to, unless there's some, you know, health reason why you have to be taking such a high dose. And you can tell by the withdrawal that happens when people try to cut back. They can't eat, they can't sleep, they're sweating. And so why go there if you have a choice? It doesn't make sense to me. You know, unless you don't know any better. And that's our job, is to teach our patients these options.
Right.
Yeah, that's so true. I've had so many patients, especially California patients, that have been on the same dose for 10 years, you know, and they're in that lower range, and they continue to get the medical benefit without having to escalate the dose. I always tell patients, if you find that your dose isn't working as well as it has been, to resist the urge to increase the dose. That's what we do in pharmaceuticals. Right. But this is a time to take a 2 or 3 day break and then start over at a lower dose. And I often find that those patients end up on their new dose is actually lower than the dose that they were on before they developed a little tolerance.
Right, right. And tolerance can be an indirect benefit, because if you lower your dose, you lower the cost. And that certainly is something we all would welcome, for sure. I think it's also beautiful in that the cannabis plant you can swap cannabinoids and still go on with your cannabis and still have effects. It's beneficial effects. That's just beautiful. How many pharmaceuticals can we say that's about? And I'm not trying to constantly put down pharmaceuticals, because there's a place for them, really. But it's just a comparison between botanical medicine, i.e. cannabis, and pharmaceuticals, just pointing out the differences. So thank you. Do you want to ask the next question, Dr. Frye, or is it my turn now? Again.
Well,
I can't remember. I can't remember.
I can ask it. Let's see. Well, you know what? I'm going to take something a little bit out of order, because, you know, with looking at the time, I know this is something that a lot of patients or a lot of advocates ask about, and there seems to be a bit of confusion about the delivery of THC via rectal suppositories. And so what's your take on that, Dr. Malka? And how might it differ from even vaginal suppositories?
Well, you know, we know that some patients are getting benefit from rectally delivered cannabis. Some of them actually feel brain effects. Some of my cancer patients who have used rectal delivery have had tumor reduction. So we know that it's getting in there. Well, unfortunately, we don't know how much is getting in. And all of the sites that talk about how rectal delivery of cannabis is so great that it's 3 times the bioavailability of oral, for example, you'll see that out there, are based on studies of THC bound to an esterified to a succinate. So it's THC hemisuccinate that was put in the suppository that has this really great absorption and really great bioavailability. Those same experiments done in the 1970s in monkeys, by the way, first, and in dogs, and then later in people. Those same experiments showed that THC in a number of different carrier bases, THC, pure THC, was 0%, 0% absorbed rectally. I'll say that again. All of those experiments through all these different animals and people show that pure THC is not absorbed rectally. I only found one article that talked about THC prepared in a different, not THC, excuse me, cannabis, prepared in cocoa butter suppository form. Only one article in the whole of the past 50 years, you know, and it said that the bioavailability was very low, less than 5%. So here we are, we're taking cannabis through rectal suppository, many of us with, not us, many people with cocoa butter as the carrier. And it could be that, you know, only 5% is absorbed. There is such a lack of studies, we don't even know. However, when they prepared this one experiment, it's from South Africa, by the way, with the THC and the cocoa butter suppositories, I think they stripped out all the terpenes, just looking at their preparation process. What we really don't know is what a cannabis extract that has a full complement of terpenes prepared in different kinds of carriers like cocoa butter or coconut oil, glycerin. There are many things you can put in there. What the absorption is of that, we don't know. I can't tell you. Some of it is absorbed, but not 3 times the amount that you get orally. No way. So, yay, somebody should do a study. It's really needed. Hasn't never been done.
Yeah.
Yeah. Yeah.
There was something on Alan Frankel's website where he did his own sort of small study looking at THC suppositories, which I assume they were not stripped down, and that, you know, he got, you know, this was dispensary acquired, and that they did plasma levels and found that the plasma levels were pretty dismal, that it really wasn't much absorption at all. So I wonder how this, you know, how it works, or actually it may even lend itself to the fact that you may not necessarily need a lot of cannabis, that if you're using suppositories and you're getting, you know, tumor reduction, that maybe less is more. You know, you're not absorbing that much, and maybe there's some critical dose where you don't get into that downside of the biphasic effect, and then that you're going to get a better therapeutic effect with lower doses. So much we don't know.
Yeah.
So much.
Yeah. I wanted to
I think it really should be studied.
Yeah, absolutely. We definitely need more information on that. And I want to point out too that rectal and vaginal use of the suppositories are definitely different. Now, if you insert the suppository into the vagina, you will get absorption, plenty of absorption. The vagina is like a sponge when it comes to absorbing, particularly cannabis, but absorbing, period. But you can get high or impaired and through the vagina. So you have to be careful. You can't say, well, if you don't, you can't say, well, put it in the vagina or the rectum. No, it's not the same thing. So we have to make sure with our patients that we make that distinction. For sure.
You know, I was not able to find one single study about pharmacokinetics of vaginal absorption. We're kind of in the same boat. We don't know what's the best carrier, and we don't know how much is absorbed, but something is.
Yes, something is, that's for sure.
Yeah.
There's one question that I wanted to ask. In your module, you talked about the different layers of cannabis, of the cannabis plant itself. You talked about the cannabinoid layer, the terpenoid layer, the interactive layer, and then you talked about the vital force as the 4th layer. Can you elaborate on that concept for me a little bit, please? I think it's fascinating.
Well, you know, we're dealing with a plant medicine. We're dealing with a plant medicine, not a purified chemical. I can't say that often enough. In understanding how to work with cannabis, you really have to think of it as a plant, not as a drug. So when you think about plants, of course, their chemistry is very important in understanding the chemical and pharmacokinetic, pharmacodynamic interactions, because those are all happening in our bodies on a chemical plane. So we've got 3 whole layers for that. We've got, what are the cannabinoids doing? We've got, what are the terpenoids doing? And then we've even given a special name to the interaction between these chemicals, which we call the entourage layer. So the interactions or the synergy between those different myriad, hundreds of compounds that are in the plant. And then I shouldn't say nobody, in general, in medicine and in science, that's where it ends. But in plant medicine, we do talk about the vital force or the energetics of the plant. When you look at some of the botany papers from long ago from cannabis, they'll talk about, you know, planting the plant according to the cycles of the moon. There's no chemistry there. But plants actually respond to the energetic forces of nature, of which human beings are actually included. So we do have an energy layer, probably many multiple energy layers to our being and how we interact with other living components. And plant medicine gives us that. So I put that all very humbly in one layer, the vital force layer, but it's probably more complex than the chemical layer. And as a matter of fact, I did an experiment with this once, just myself for fun. And I had the terpenes extracted from a whole bunch of cannabis. And I had this tiny little dram bottle of terpenes from a plant that was supposed to be uplifting, a cultivar that was supposed to be uplifting. And I also did something called a flower essence preparation, which we don't hear about in medicine, but exists in the natural health world. Flower essences are when you capture the essence of the plant and you put it in a little dropper bottle and you put some drops under your tongue, and lo and behold, you feel things. So I made a flower essence of this plant and I extracted the terpenes, and then I kind of alchemized them or homeopathically prepared the terpenes. So we have like the most aromatherapeutic aspects of the plant and the energetics of the plant. It worked great, made people feel wonderful. Then we're taking, barely any terpenes, if any, and no cannabinoids whatsoever. So there definitely is an energetic vital force to the plant kingdom, and we have not yet begun to harness it. Although there is such a thing as a cannabis flower essence that you can buy online. So I didn't make that up. And that's a whole nother world, isn't it?
Fascinating. So much we don't understand about these botanicals, and we have all these gifts here for us, and we've kind of tried to synthesize them and reduce them to single molecules when there's so much, abundance in that whole plant. Yeah. Thank you for that.
Yeah. And you're right. There are some things that just cannot be reproduced from the plants. And that's the value of having an herbalist, as being an herbalist and a medical physician, because you can understand a little bit more of what's going on with using cannabis, which is a botanical medicine. So that's an aspect that I appreciate you delving into. And it is in the module if anyone wants to learn a little bit more about it. And do you want to start asking the audience questions? Should we do that now?
Yeah, I was taking a look. We're coming up on, we have about 15, 20 minutes. So let's see what the audience is asking. So, the one question was that the one person wanted to understand better how to advise dosing for individuals with severe nausea and vomiting from chemotherapy. Are there any best practice rules of thumb?
Sure. Well, that's where the delivery matters. Obviously, you're not going to use an oral method, although, so vaporizing THC or CBD should give immediate relief to nausea within 10 minutes. That's one method. Another method that some people use who don't want to inhale for whatever reason is using the sublingual mouth spray, and just spraying it into the mouth. And lastly, suppositories can be tried. We don't know what dosage we're getting, but you can try them. So no oral, and otherwise you're fine. And do do want to say again about dosing. There is no one amount of dose that I could ever say somebody should take for something, because it depends on all those factors. You know, whether they're new, whether they're chronic, whether they have a tolerance, what their own system is. So for everyone who does cannabis for anything, it's individualized dosing. So you start with 1 puff, then you go to 2 puffs, you start with 1 spray, you go to 2 sprays. This is not rocket science, but you know, I would never say, oh yeah, 2 sprays will do it. We don't know. It's up to the individual.
Yeah. Cannabis is definitely an individualized medicine, for sure. There's another audience question that was about the nanotechnology. Can you comment on nanotechnology delivery systems? Any concerns regarding metabolism, excretion, effectiveness, etc.? Like, what are we actually doing to the plant when we're using this technology?
You know, I am not that well versed in what the technology is. I know a little bit. I know that the problem is that our cellular chemistry lives in an aqueous environment, which is not conducive to cannabis delivery into the cells, because cannabis is lipophilic. So the nanotechnology tries to liposomalize or encapsulate, you know, minute nanogram amounts of cannabis in a form that cells can take it in, you know, that's more hydrophilic. So in that's good, because you get more bang for your buck if it's going to get, you know, delivered more effectively. Unfortunately, and I'm not sure about this, probably most of the preparation techniques are likely to exclude some of the terpenoid content, if heating's involved at all. So if they do it all in the cold, I mean, that's what I don't know. I don't know the technology, but I would think that they might be losing some of the entourage there.
And that's a concern with all sorts of any sort of processing or extraction that you're doing with cannabis. Anything other than the flower and vaporizing it, you're going to lose something. So you're right about that. That is an issue. Interesting.
All right, I'm going to go to the next question. So we'll try to get as many of these in. So for the provider who is concerned about knowing exactly what's in the medicine. So the question is, what's your opinion on standardized lab testing? Clinicians like us can't begin to talk about confident dosing if we're unsure of the actual constituents in the product we are recommending. What's your answer?
You know, I totally 100% agree. It's a big line in my module in capitals. When you don't know what's in your product, standardized dosing protocols are impossible. So anybody who's doing homegrown cannabis preparation, it would be awesome if they could afford to, and if they went to the trouble to send their sample in for chemical analysis to find out what's in the product. I think it's essential. Unfortunately, the full terpenoid complement is not necessarily analyzed on a routine basis. So we're only getting a partial chemical analysis. And I could be wrong. Somebody else is better at this than me. I do know that there's a heavy metal and a pesticide and a mold screening that is available. I don't know that it's routinely done on the products that are sold at dispensaries. And I think it varies from state to state as well.
It definitely depends on the state and the requirements. In the state of Florida, there's a mandatory requirement for the cannabinoid testing and mold microbes, and that's about it. They don't demand heavy metal testing. They don't demand terpene testing, and I could be a little bit off on that, but yeah, it depends on the state for sure.
Yeah, and for patients who do grow their own and want to send it in for testing, you can certainly request a terpene profile as well as a cannabinoid profile. And unfortunately, without regulation, it's every man for himself, from state to state. But certainly, if you're in a legal state and you are growing a THC dominant plant, you could send it to a lab within your state. If you are growing a plant that's quote unquote hemp, less than 0.3% THC, or at least if you think it is, then there are labs around the country where you could send a sample to a lab in another state. Although there are some restrictions with sending flower, but let's say if you made an extraction, if you did an oil or alcohol extraction, you could certainly send that in a syringe or a vehicle that you could send interstate to get it tested. But if it's a high THC product, you really should try to find a lab within your state that will do the testing for you. So our next question was about tolerance breaks. And the question is, do you suggest increasing the dose of CBD or THCA when taking a tolerance break? I'm sorry.
So I'm assuming this person is taking a tolerance break from a THC dominant cultivar, I'm assuming. So yes, some of the things that THC is accomplishing in your body can be accomplished by other cannabinoids. It depends on what you're treating. Some by THCA, some by CBD. Someday out there, THCV, which is a propyl analog of THC that's not very psychoactive, binds differently to the cannabinoid receptors. Maybe that'll be available, but definitely switching your cannabinoid out is better than cutting it out entirely if you're having withdrawal issues. If you're not, if you can take one day a week off as a regular protocol, I say do it. That's just a smart way to use cannabis.
Yeah, without question. Now, and thank you for that, Deborah. I know you also talked about raw cannabinoids in your module, and an audience member wanted to know, are the raw cannabinoids truly more bioavailable and in lower doses than with the decarboxylated cannabinoids?
The bioavailability of cannabinoid acids is not something that I found a lot of information on. Obviously, they're more polarized, so they're more likely to be soluble in an aqueous environment. But right off the top of my head, I do not have bioavailability figures. And I've looked, so they're probably out there, but I didn't find them. So I would not be able to say that they're more bioavailable at lower doses than other cannabinoids. Can't say that. Maybe they are. I don't know.
And Deborah, I
maybe somebody else knows.
I think I saw fairly recently a study looking at absorption of THC, THCA, and CBD, CBDA. And at very similar doses, plasma levels for the acids were like 30 times greater than that of the neutrals. So that particular study certainly suggests that there's increased bioavailability due to while it's still lipophilic, it's more hydrophilic than the neutrals, so that may enhance absorption. And we certainly see it clinically with lower doses of CBDA and THCA. At least that's what I see, is that patients who are using acids tend to respond to lower doses. So I encourage all patients, we don't have leaves and things here to juice and whatnot, but I encourage them to buy some buds and make tea and sip on that. That's something else I learned from my elderly California patients very early in my practice, is that, oh yeah, I make tea and I sip on it and it helps my arthritis. And a lot of those older patients really don't like the impairing effect of the THC. Not everyone experiences a euphoric high. And there's a question, and there was a comment about that. And I just wanted to touch on that, is that the euphoric high is great for patients who enjoy it or who need to get kind of out of their heads, or a respite from illness or worry or anxiety, but not everyone experiences it. It can be quite dysphoric for many patients, and they go to great lengths to avoid it. So when we talk about adverse effects, we all realize that the euphoric high from THC can be quite therapeutic, quite beneficial for many patients. But there are patients who don't like it, who are made quite uncomfortable by that effect. And so we wrestle with what to call that. Some people say, well, psychoactive isn't appropriate because the plant has non-impairing psychoactive activity in terms of reducing anxiety and mood elevation. And some people like intoxication. Other people don't like that word because it has the word toxic in there, and it implies that it's toxic or something bad. So we're still wrestling with, how do we describe this altered state, which can be beneficial for some people, but not so great for others. So let's see, let's go on to the next question. In light of the, saludos de Buenos Aires, Argentina. Bienvenido. Any experience with vaginal or rectal suppositories for treating mucositis? This is a rather specific question. In patients doing pelvic radiation therapy, do you think absorption of cannabinoids could be greater in an inflamed mucosa?
Wow. I might have to defer that one to Dr. Wilson King, who's a specialist on vaginal mucosa compared to me. Can I do that, Janester?
Sure you can. Sure you can. Again, there really aren't any studies. I can only base my answer on clinical experience. And I've had a few patients with who had pelvic radiation for various conditions, and the discomfort was treated with a vaginal cannabis suppository. And their doses didn't seem to be different than any of my other patients' use of vaginal suppositories, say for pelvic pain related to endometriosis. So I don't see a major difference, but that's only based on clinical experience and with a few patients. So we definitely, that's another area in which we need study. There's a lot of studies that are needed in women. For example, the menopausal or postmenopausal woman is different than the woman of reproductive age hormonally. Therefore, we need to look at how cannabis is interacting in those folks as well. Now, in reference, I see somebody made a comment about vaginal atrophy. Sure, cannabis is may be effective for the pain in vaginal that people experience with vaginal atrophy in their attempt to have sex. However, vaginal atrophy is best treated with hormones. very low dose. You can actually even use the mild form of milder form or less potent form of estrogen, and that is estriol vaginal cream, which actually is approved for women who've had breast cancer and want to maintain vaginal function. They can use an estriol vaginal suppository, or they do have some very low dose estradiol vaginal suppositories that will be very effective in those instances. So I do, cannabis doesn't have to be used for everything. There are other modalities and things that can be used to help various conditions. But cannabis certainly is helpful with respect to any type of pain, particularly pelvic pain. So.
And going back to inflamed mucosa, this doesn't really pertain to that, but the reason that THCA doesn't have the same effect as THC is presumably it doesn't cross the blood-brain barrier due to that carboxyl group. But we find that THCA can be helpful in treating my experiences in pediatrics with seizures. And so the question is, well, if it's not crossing the blood-brain barrier, how is it affecting seizure activity? But again, those kids typically have inflammation. There's a lot of neural inflammation. And so perhaps because of that inflammatory state or inflamed state, that affects the permeability of the blood-brain barrier, and certainly may, so an inflamed mucosa in the vagina may certainly, the permeability may be altered as well. As in the rectum, we don't really talk about that. We use sometimes those suppositories for proctitis or ulcerative colitis that's confined to the rectum, and we get we see symptom relief as well as histological improvement, but we don't know if that's because it's being absorbed or because it's activating local receptors. So Debbie, here's another question about about vital force. In light of your comments on the vital force, do you feel that synthetic cannabinoids and terpenes produce the same physiologic effects as those derived from the whole plant and cannabis extracts? A lot of our basic cannabis research, especially in pregnancy, is based on synthetic cannabinoid isolates.
The answer is personally, absolutely not. I don't think they're the same. And I actually, there have been studies that have been done with pure cannabinoids plus a certain amount of terpenes added compared to full plant extract. And the full plant extract always, at least in the studies I've read, seems to work better and is more effective at a lower dose than the synthesized chemicals trying to be reconstituted. So first of all, they may not get the reconstitution exactly chemically correct because there's so many terpenes to consider, there's hundreds. And second of all, if you talk to anybody who uses raw cannabis, they will tell you that it's probably the best of all the cannabis delivery systems for chronic disease and fatigue. There's some energetics that's happening there, and I'd hate to do without it when it's available. Why strip it out?
Right.
Okay.
Well, we're at the top of the hour. Dr. Wilson King, did you have any other questions?
No, only more comments and wishing this could go on longer, but it's just an hour, and it's been a very productive and hour of plenty information for sure. I've enjoyed all of this this conversation, Dr. Malka. It's been really, really very, very nice. And you as well, Dr. Frye. Always love talking to the ladies for sure.
Yeah. Superstars. Thanks for having me.
Yeah, thank you so much. Thank you for all the energy and effort you've put into your amazing module. I hope that people get as much out of it as I did. And I have to tell you that in 2015, when I first took the SCC's clinical curriculum, which helped me immensely, the one module that really helped me a lot was yours. And I remember your case study of the person with pain and having trouble sleeping and how to dose during the day and what to give at night to last through the night, and how those adjustments were made. And I found it to be so helpful to me clinically. So I just wanted to share that with you. So thank you everyone for your time. I'm sorry we didn't get to all of the questions, but I think a lot of things will be answered in Dr. Malka's module. So take advantage of the discount for today. And I'm going to turn things back over to Genesis.
All right. Hi, everybody. It's Genesis again. Thank you so much for joining us for this afternoon segment of Canna Talk featuring Dr. Frye and Dr. Wilson King and our lovely course author, Dr. Deborah Malka. I hope you guys thoroughly enjoyed our discussion and found so much valuable insight and educational clinical highlights from Dr. Malka's course. As always, you are welcome to visit the SCC course curriculum page to purchase Dr. Malka's course. Again, it is on current promotion as our featured course of the month. It's 15% off for non-members and 20% off for SCC members. The 15% off discount code is LearnDosing15, which I did share in the chat. And again, you guys can purchase that for a limited time offer at the discounted price. Please also check the SCC events page so that you guys can mark your calendars for the SCC's upcoming events. We do have a journal club coming up on July 2nd and also our quarterly meeting on July 11th. And then our next Canna Talk segment is going to be on Thursday, July 22nd. So please be sure to check us out for those upcoming events. Someone just asked, is the same code for members? The code is not the same. So members have an exclusive code that you'll use for your 20% off discount. And then the 15% off discount is for non-members. And again, that one is LearnDosing15, which I will share in the chat now. And if anyone has any questions, you guys are welcome to email me. My email address is genesis@cannabisclinicians.org. Other than that, thank you so much for your continued support for the Society of Cannabis Clinicians. Thank you guys for being members. For those of you who are, and for those of you who aren't, what are you waiting for? It's time to join the SCC. Thank you so much. We'll see you soon. Thanks for joining Canna Talk. Bye, everybody.
All right. Bye, everybody.
Bye.
Namaste.
Good job.